Hi, good morning, everybody. I am here to present one very important topic, in my opinion. It is very important topic, and where there is a morning, it is a more good morning. Where there is a evening, there is a good evening. It's me, Dr. Mohammad Kazafi. You are watching Dr. Mohammad Kazafi Views, and this topic is a odontoid fracture. The patient, I want to take one case like an analogy, and then definitely I will present this lecture in detail as per the need of the topic. So here the patient is a 64-year-old male who presented after a fall from a bicycle, and he was brought to the emergency department where he complained of neck pain. Past medical history, mitral regurgitation and hypertension, and a further examination shows there is a 5/5 strength throughout both upper limb and the lower limb, sensation intact to the light touch throughout, and the normal reflex pain with palpation of the posterior cervical spine. Here, my differential diagnosis is the fracture of the odontoid may occur in the setting of trauma or neoplastic infiltration of the dens, either primary or metastatic tumor. Osteomyelitis may induce the odontoid fracture. Degenerative changes seen in the rheumatoid arthritis, osteoporosis, and metabolic bone disease may cause these kind of problems. Here, initial imaging with CT revealed a type 2 dens fracture, and the best despite on sagittal and coronal views, and the MRI imaging showed no evidence of the transverse ligamentous injury, but there was evidence of the anterior perivertebral swelling and mild C1, C2 interspinous injury. And the differential diagnosis is limited to the traumatic fracture of the dens, and there are no imaging characteristics that suggest other etiology for the fracture, and especially giving the patient's history, such as we did some workup here. And as you know, the CT scan revealed already this is a type 2 dens fracture, and but I did the MRI because I want to confirm over that. And you know that the ligamentous injury has no evidence, so it is very important information regarding the management of odontoid fractures. So as you know, here we usually do the further workup such as the laboratory workup, routine lab, CRP, ESR, just to rule out the infection, and MRI cervical spine I already mentioned to assess the transverse ligament. Alternatively, flexion and extension films may be obtained in a neurological intact patient if MRI is not available, but the CT scan cervical spine to assess for the other fracture at C1 or the subaxial cervical spine and fracture. So the AP lateral and open mouth odontoid views, plain X-ray is done, and which shows there is a type 2 and confirm over the CT scan. Little bit about this case. As you know, using if I want to use the Anderson and Alonso classification system, so the Anderson and Alonso classification, dens fracture are usually defined as type 1, type 2, type 3, and type 1 fracture involve the tip of the dens and are rarest form. Type 2 fracture involves the base of the dens, and the type 3 fracture extend into the body of the C2. So I was talking about the Anderson and Alonso's classification system, which is very popular regarding the dens fracture, and usually defined as type 1, type 2, and type 3. Type 1 fracture involve the tip of the dents and are the rarest form, and the tip and the type 2 fracture involve the base of the dents, and type 3 fracture extend into the body of the C2, and the type 2 fracture are the most common, and in our patient they are the type 2 fracture, but also the most difficult to manage. Type 2 fracture traditionally have the greatest ununion rate when managed non-operatively, and the most important factor regarding prognosis include age more than 65 age, and significant angulation, significant displacement and distraction. So the posterior displacement of the dents, displacement in more than one plane, and delay in the diagnosis. So these are the factor which can complicate some kind of management in certain reason. The fracture of the dents require a combination of both horizontal shear and vertical comprehensive force. In younger patients, high impact mechanisms are usually required to cause of the fracture of the dents, and the ground level fall account for the majority of the fracture in the elderly population. It is also important to note that the coexistent injury to the atlas and the subaxial cervical spine may be present and should be assessed on imaging and physical examination. It is very important to exclude any other injury here. So I want to mention here that odontoid process or dents is a superior projecting bony element from the second cervical vertebra or the axis, and the first cervical vertebra atlas rotates around the odontoid process to provide the largest single component of the lateral rotation of the cervical spine. As you know, the fracture of the odontoid process is classified into one of three types, and which are type 1, type 2, type 3 fracture, and depending upon the location and the morphology of the fracture, the most common mechanism of injury is the hyperextension of the cervical spine and pushing the head and C1 vertebra backward, and this activity views the etiology, presentation, evaluation, and management of the fracture of the C2 dents. And my purpose to presenting this, I want to show you the role of the interprofessional team in evaluating, diagnosing, and managing the condition, describing the unique vertebral anatomy of the second vertebra axis, including the odontoid process. And I want to discuss here, or I want to explain the component of the proper evaluation and the assessment of the patient presenting with potential odontoid process fracture, and include may indicate any including any indicated imaging study. I want to summarize the treatment and management strategy variable from the C2 odontoid fracture based on the specific fracture type, and I want to discuss the importance of the interprofessional team strategy for improvement or coordination and communication to aid the prompt diagnosis of C2 odontoid fracture and improving outcome in patient diagnosing with the condition. As you know, the odontoid process, the dents, is the superior projecting bone element from the second cervical vertebra, C2, or the axis, and the first cervical vertebra rotates around the odontoid process to provide the largest single component of lateral rotation of cervical spine. Fracture of the odontoid process is classified into one of three types: type 1, type 2, and type 3 fracture, depending on the location and the morphology of the fracture. Odontoid fracture occurs as a result of the trauma to the cervical spine. In younger patients, they are typically the result of the high energy trauma, and which occur as a result of the motor vehicle or diving accident. And in the elderly population, the trauma can occur after lower Energy impacts such as fall from the standing position, and the most common mechanism of injury is a hyperextension of the cervical spine, pushing the head and C1 vertebra backward. If the energy mechanism and the resulting force are high enough, the patient's bone density is comprised secondary to the osteopenia or osteoporosis. The odontoid will fracture with varying displacement and the degree of the communication. So the odontoid fracture can also occur with hyperflexion of the cervical spine, and the transverse ligament runs dorsal to the or behind the odontoid process and attached to the lateral mass of the C1 on the either side. And if the cervical spine is excessively flexed, then transverse ligament can transmit the excessive anterior force to odontoid process and cause an odontoid fracture. As you know, the odontoid fracture account for 20% of the cervical spine, and the fracture in the adult population and are the most common fracture subtype in geriatric population more than 65 years. The axis C2 is the most common vertebra to be involved in the cervical spine injuries, and the odontoid fracture account for 50% of all C2 fracture. This shows bimodal distribution with peak among early adults and elderly population. As you know, the odontoid fracture results from an interaction between the load magnitude and bone quality. This results from the high impact force in young cohort, but with trivial injuries among elders. Hyperextension injury cause the skull and C1 arch to cause traction of the odontoid process, while the hyperflexion injury causes the transverse ligament to limit the posterior movement of the dens. And the type 2 is the most common type of the odontoid fracture and account for over 50% of all odontoid fracture. So the type 3 odontoid fracture make up most of the remaining odontoid fracture, and type 1 odontoid fracture are rare. So the road traffic accident are accountable for the majority of the cases. In study comprises more than 30,000 patients, and the average age of cohort was 77 and 54% were female. So you understand that it is happen in more in the elderly age and more in the female, especially 54% females are involved. But I think I may consider the equal in somehow. But as you know that the pathophysiology, advanced age, and the large occiput C2 angles are the predictive of the odontoid fracture angle. The atlantoaxial joint and the fracture segment all move in unison. So using unbearable pain during neck movement, the non-union rate following conservative management can be as high as 90% owing to thin bony trabeculae and the watershed zone at the base of the dens. Non-operative management of the odontoid fracture can result in the following, such as the solid fusion, unstable union, or fibrous non-union. So you know that the non-operative management is also need almost very strong support, such as the solid fusion, unstable non-union, or fibrous non-union. And the fusion is governed by the following pattern of injury: fracture subtype, the slope of the fracture line, the angulation if more than 11 degrees, and the displacement more than 5 millimeters, blood supply, bone quality, and the age of the fracture and the age of the patient. So these all are very, very important factors considering and to understanding the pathophysiology of the this kind of occiput C2 or the odontoid fracture, and how to deal with that. It is very, very important. 90%, as you know, we are treating it conservatively, but only 10% sometimes we need to do with the help of surgery, and what surgery we will do definitely we will discuss. But I want to present how patients are presenting in front of you and how we are examining or how we are assessing him or diagnosing him. Actually, younger patients with the odontoid fracture typically have identifiable recent trauma such as the motor vehicle accident, and a sports related impact, diving accident, fall from a height or a downstairs, and other patients tend to have less resilient bone and can sustain an odontoid fracture after a minor trauma, so including the falling from the ground level or running into a door or a cabinet. However, the older individual can also sustain an odontoid fracture from recent injuries similar to those of the younger people. On physical exam, patient may note cervical neck pain, and which is worse with motion, and they can also have dysphagia due to the retropharyngeal hematoma or associated parapharyngeal swelling. As you know, the less commonly the patient may have myelopathic spinal cord injuries such as the paresthesia in the arm and the legs, or the weakness of the arms or the legs, and the other neurological dysfunction. There are fewer spinal cord injuries in the odontoid fracture due to the relatively large cross-sectional diameter of the spinal canal at the level of the odontoid process compared to the diameter of spinal cord. Evaluation, the X-ray of the cervical spine constitutes lateral, anterior, posterior, and open mouth views. So although radiograph yield lower sensitivity and specificity rate when compared to the computerized tomogram scan, experienced clinician and practitioner can still appreciate suspected injury without CT utilization. In addition, flexion, extension radiograph should be obtained in the setting of the suspected occipitocervical instability useful in type 1 odontoid fracture or the setting of an os odontinium. So initial instability on upright radiograph is associated with stability on following or the follow-ups of the patient. Computerized tomograph scan provide the best resolution of the bony element, allowing for the identification and characterization of the odontoid fracture, and this also allows recognition of the anatomical anomalies such as the defect of the posterior arch of C1 that can help plan the management strategy, and the CT angiogram or CT angiography is justified in case with the fracture extension within the vicinity of the vascular zone and assessing the course of the vertebral artery during posterior fixation. Magnetic resonance imaging to assess the integrity of the transverse ligament as well as the cord among the patients presenting with neurological deficit. Classification of odontoid fracture type 1 and type 2 evolving such as the type 1. I just want to explain here because MRI also explain the classification of the odontoid fracture. So I just want to explain you in that manner. The type 1 involve the apex of the dents and is mostly stable. They are rare. If unstable due to the avulsion of the LR ligament is suspected, then LR ligament avulsion is suspected and dynamic ratio imaging is advocated. In type 2 involve the neck of the odontoid process, and they are categorized depend on the pattern of the fracture line into the anterior oblique, posterior oblique, and horizontal variant. They are the most common subtype and they are mostly considered unstable. That's why the type 2 is divided further into the type 2A and type 2B and type 2C according to the Guarer's classification, and this is suggestive that the type 2A has comminuted fracture at the base of the dents and is unstable, not displaced as I told you, there is the type 2A, non-displace and non-communication. So it is called type A. Type 2 fracture, lining or the line running anterior superior to the anterior inferior direction. So this is called the type 2B, and the fracture line running anterior inferior to posterior superior or with significant comminution, which is called the type 2C. So type 3 definitely is very simple and to understand, because the fracture extending into the body of the C2, and this is a non-surgical treatment, remains preferable option for the majority of these patients, and such kind of patient usually respond conservatively very well. So here I want to present you the treatment and the management of the odontoid fracture. As you know, achieving the fracture stability is the mainstay of the management, and the fibrous union can provide adequate stability. Without instability on flexion extension views or the ligamentous injury on the MRI scan, a rigid brace or the halo vest is enough and can be used to promote healing of the fracture, which may occur in about up to 12 weeks. A conservative approach may be justified for patients with the following conditions, such as the good alignment with no dynamic instability and no deficit. But type 1 and type 3 fracture usually treated conservatively, and the halo fixation or the cervical traction and the rigid cervical collar results in fusion in, and the type 100% of the type 1 in the majority of cases treated conservatively. Approximately 90% of the type 3 fracture has been treated conservatively, but 60% of the type 2 fracture has been treated conservatively. Rest of the 10% of the type 3 and 40% of the type 2 treated surgically, and the cervical collar is biomechanically superior to the halo orthosis with minimal risk of the concurrent device related complication. So the soft collar provides comparable benefit in aged patient compared to the rigid collar, and the use of the halo vest was not associated with increased mortality. So the conservative treatment and surgery had similarly low in hospital mortality. So the indication for the surgery in type 2, I want to present you the indication for surgery in type 2 fracture: unstable fracture, irreducible fracture, non-union, and patient with the deficit. As you know, the criteria for instability: fracture age equal to or more than 6 months. 6 months, I am telling 6 months. Yani, if a fracture, then you can consider this could be the case of surgery. Otherwise, no. Means fracture age equal to or more than 6 months. Comminuted fracture, rupture of the transverse ligament, or comminuted fracture, or means fracture age more than 6 and it is not healing, then you can proceed. If patient has comminuted fracture, then you don't have to wait. You try some time, but you can proceed. Rupture of the transverse ligament, it is an indication. Non-reducible or mal-aligned fracture pattern, dense displacement more than or equal to the 6 millimeter, then don't wait, do surgery. Angulation greater than or equal to the 10 degrees or more, then you have to proceed for the surgery. And fracture gap more than or equal to the 2 millimeter, then also a reason you can proceed for surgery. And the lateral mass gap more than 2 millimeter, then you can proceed for surgery. Both anterior and posterior fixation technique have equivalent clinical result, and the anterior odontoid screw fixation preserve neck movement while providing fusion rate about 80 to 100%. And the posterior inferior fracture type and the concurrent tear of the transverse ligament are selected for the posterior fixation. Historically, the posterior cervical fusion was undertaken by Brook, Galley, and later Dickman and Sontage. And this is a Sontage method and incorporating to the use of the sublaminar wire and the bone graft and providing a fusion rate of 86%, and this was followed by the transarticular screw the transarticular screw as described by the Jenrette and McGrail, and which provides almost 100% fusion. So the goal harness technique C1 lateral mass and C2 pedicle screw is now an excellent alternative to the anterior fixation, and after the advent of the goal posterior joint manipulation technique, most of the once incredible atlantoaxial dislocation and could be reduced, and the need for the transoral odontectomy become almost nil. Bone grafting provide long-term stability. Sublaminar wiring can impinge upon the spinal canal, and C1 C2 joint fusion restrict neck range of movement. So, as you know, the Nakanishi described the technique of the anterior odontoid screw fixation and anterior fixation as advocate for the fracture less than 6 month old and anterior inferior sloping fracture line, so the transfers without any communicating segment at the base. There is no need for the bone grafting and minimal risk of injury to the vertebral artery. There are also mild limitations in the functional ability following the procedure. Prerequisite for the anterior odontoid screw fixation include intact transverse ligament and reduction and proper alignment following traction. A bicortical purchase and the superior and the posterior breach of the odontoid tip significantly govern post-operative alignment. Leg Herbert and the actuated screws are used for the anterior odontoid fixation. Both single or two screws anterior odontoid screw have shown similar clinical results, and there are anatomical limitation and variability in the placement of the two odontoid screws. Subset not appropriate for the anterior odontoid screw fixation include the type 2A fracture are not good candidate for the screw fixation, anterior screw fixation. The rupture of the transverse ligament, also the same associated atlantoaxial dislocation, osteopenia, more than 6 months of the injury, anterior oblique fracture slope, and a short neck, barrel-shaped chest, and the severe kyphosis. So these are not the good cases for the anterior screw fixation, and the recent advance in assessing the instrument include the O-arm navigation, a 3D and the 3D print model, endoscopic approach, robotic CT, guided imaging, all are the recent advances. And yes, because the robotics also involved, endoscopic approach involved, the 3D print models we have, O-arm navigation helping us, CT guided navigation helping us. So these are the few new or the advanced gadgets. They are helping for the evaluation and the treatment simultaneously. So the odontoid screw fixation technique is not recommended for children under the age of the 6-year-old, and the technique is feasible for children age 6 to 18-year-old. Appropriate screw diameter, length, and the angle according to the actual CT measurement result in critical, and anterior approach is more suitable for younger cohort. There is a level 2 recommendation for the surgical stabilization in geriatric patient due to the high risk of high non-union and that's why the meta-analysis have revealed better fusion with the posterior fixation, and this is the high risk of the reoperation rate owing to the osteopenia following anterior odontoid fixation, and there are also an increased risk of the post-operative pneumonia and a swallowing dysfunction and increased technical problems. So there is a marked variation in the treatment strategy as well as follow-up and the imaging algorithm. Major comorbidities and the older age are significant factor in refraining from surgical fixation. The proportion of the crossover from a primary external immobilization to surgery was 14.4, whereas the proportion for the revision surgery in the primary surgical group are 10%. Operative treatment was shown an average increase of the 3.4 per year, and the operative management nearly doubled between 2003 to 2017, and for managing geriatric endopathetic fracture. So the Level 3 increased sagittal balance and the bone fusion with the atlanto-odontal interspace confer a high risk of the non-union. So the duration from the injury to the surgery more than 7 days appear to have 48 times higher risk of non-union in elderly patient despite anterior odontoid screw fixation. What I did for my patient, I just want to present in front of you. You know, there is, as we discussed already, the treatment option depend on the type of the fracture. So, and as you know, and the surgical correction is the requirement of my patient because he was a type 2 fracture, and it is very much indicated for communicated or comminuted or the displaced fracture with or without transverse ligament injury. So the posterior fusion we chose, and with the help of the sublaminar wiring, Bruce, Galley and Thorntard, and the articular C1 C2 screw fixation and the segmental screw fixation. These are the options with us. So require a favorable C1 and C2 bone anatomy for the screw placement, and should be avoided when there is a high riding or the medially coursing vertebral artery. So that the technique the technique when feasible has been shown to have a higher fusion rate. Definitely, when we did the surgery for our patient, and we noticed that he needs a more stability, so we did the surgery early. We didn't wait too much, so that's why we went for anteriorly also, and we did anterior odontoid screw placement. So I just want to tell you, I took this case because we treated this patient 360 degrees, means anterior and posteriorly, and you know the odontoid screw is useful in patient with acute and subacute fracture, and contraindicated only the barrel chest patient and patient with the short neck. So my patient has a neck is not short neck or not very long neck. It is the average size of the neck, and not angulated or displaced fracture. So the and patient has the transverse ligament injury was there, but it was not very obvious. So we chose also to put the anterior odontoid screw placement, and patient is a position in a supine position. Before instrumentation, a large radiolucent bite block should be placed by the surgical team, and 2 C-arm are placed in the we can say orthogonal orientation for the biplanar visualization of the dents, and the lateral and open mouth views of the dents and the body of the C2, and should be easily obtained before skin incision. And we perform a standard incision at the C5 C6 level, and the blunt dissection is carried down to the pre-vertebral fascia, and further blunt dissection with the Kittner's dissector is then and carried superiorly toward the C2 and C3 disc space, and the self-retaining retractor is placed to allow the visualization of the C2 and C3 disc space and the base of the base of the dens, and to protect the soft tissue. And once C2 and C3 disc space is exposed, a small and through is a drill in a caudal C2 body in the midline, and the drill is used to create a hole in the body of the dens, and this hole is extended across the fracture line in the tip of the odontoid, and the lag screw is placed through this pilot hole, and the lag screw provide a comprehensive force that pulls the fracture fragment toward the base of the dens and enabling fusion to occur across the fracture. So, for the posterior instrument fusion, the patient is placed in the Mayfield head holder and the turn prone on the chest roll, and the patient is placed in a slight reverse Trendelenburg position with the knee flags, and the before skin incision lateral fluoroscope is used to ensure adequate alignment, and the incision is centered from the inferior occipital lobe or inferior occipital bone to the C3 spinous process, and the C1 and C2 posterior element are then exposed with electrocautery, and if screw placement is planned, the medial portion of the C1 lateral mass are exposed and palpated with the 4-fan field, and the C2 nerve root should be mobilized inferiorly, and alternatively may be sacrificed during placement of C1 lateral mass screws. Judicious use of the fluoroscope should be used during the placement of the C1 screws, and the C2 screw may be placed in the pedicle or the pars interarticularis, and depending on the patient's anatomy or pre-operative CT, and the alternative to C2 pedicle screw is interlaminar C2 screw fixation. After placement of the screw or the or we can say the sublaminar wiring, the cortical bone overlying the C1 and the C2 region should be decorticated, and autograft and allograft are placed over the decorticated region to achieve bony fusion. And as you know, avoidance and the complication avoidance and management during the placement of the C1 screw, it is important to note that the length of the screw on the lateral fluoroscope and the screw is at the depth of the anterior trabeculae of the C1 on anterior breech is likely, then it should be avoided. And high drilling or the medial oriented vertebral artery anatomy may make placement of the C1 and C2 screw unfeasible, and if this is the case, then the alternative fixation with the intralaminar screw and the wiring or hybrid construct may be considered, and if necessary, the construct can be extended from the occiput to the subaxial and cervical spine. Anterior odontotomy screw fixation should not be performed in patient with the atlantoaxial instability, and that's why we consider this case. It is not too much atlantoaxial instability. That's why we put the screw, just to make sure that we can give a good support for him. And the pre-operative MRI should be used to assist transverse ligament injury, and we did so. And we found there is no transverse ligament injury, or there is a suspicion of the transverse ligament injury. So the additionally significant displacement fracture that cannot be reduced or chronic fracture with decorticated surface are not candidate for the odontoid screw fixation. I just want to present this case in front of you, just the few last thing I want to mention here about the os odontonium. Os odontonium is a recognized anatomical variant of the normal C2 odontoid process, and during the development, as you know, there are multiple ossification centers in the spine, with one being is the odontoid process on the odontoid tip and the one in the vertebral body. body. If the ossification center in the odontoid process and the vertebral body fails to fuse, then the odontoid process dents can appear to detach from the vertebral body and mimic the type 2 odontoid fracture, and ossification can also mimic a type 2 odontoid fracture. So that's why sometimes it need to treat. And the persistent ossiculum terminale, the rostral tip of the odontoid process has a separate ossification center during the development from the remaining odontoid process, and when the two ossification center fails to fuse, there has been the persistent gap between the odontoid process and the tip of the odontoid process, which can mimic a type 1 odontoid fracture. As you know, the prognosis is very much dependent upon the children's. For example, children achieve the stable fusion with halo immobilization. However, patients over 50 years of the age have 21 times higher risk of non-union with halo immobilization, and the fusion rate is 88% when the surgery is performed within 6 months of allowing a fusion rate of 88%, but it is a drop to 25% when the surgery is performed more than 18 months after injury. If the patients fail external immobilization and within 6 months of the injury, anterior odontoid screw placement is still an option, and you can use this option. Displaced distal fracture segment of the facetal alignment causing cervicomedullary compromise and irreducible disappoint traction previously, and required transoral resection preceding posterior fusion. Anterior extrapharyngeal open reduction and internal fixation have now been introduced to manage the same complication. As you know, there are the mortality at the time of injury is observed with 25 to 40% of the patient, and most of the survivors are usually neurologically intact. However, this can be harboring the risk of the instability at the atlantoaxial region and the spinal cord injury, so causing the Brown sequard syndrome and a spinal cord transection, cruciate paralysis, myelopathy, persistent disability, neck pain is around 25% of patients. There can be concurrent injury associated with and complication with odontoid fracture, which includes the anterior cervical wedge fracture, atlanto-occipital dissociation, cervical bus fracture, cervical facet dislocation, cervical spinous process fracture, extension cervical teardrop fracture, flexion cervical teardrop fracture, hangman's fracture, isolated transfer process fracture, and Jefferson fracture. So here, as you know, the post-operatively patient should be monitored for the retropharyngeal hematoma, dysphagia, aspiration, vocal cord paralysis, surgical site infection. The patient need to understand this sign and symptom and contact their surgeon's office immediately if this patient present. So you know the team has been required for that, and the trauma team, definitely neurologists, radiologists, all are required in this thing. So I hope I tried to explain a little bit about this case. I hope you will like it. If you like it, just please subscribe and share with us or with other people. Thank you so much. I know you are helping us. Thank you. See you in the new lecture.